Hello, this is Andrew Hill from MedStar, Georgetown and Washington Hospital Center in D.C. Today, I'm with Dr. Philippe Genereux, the director of the Structural Heart Disease Program at the Gagnon Cardiovascular Institute at Morristown Medical Center in New Jersey. This morning, we're here to talk about the trial he just presented at ACC, Incidence and Impact of Acute Valve Syndrome Before Aortic Valve Replacement, Insights from the EARLY-TAVR trial. Dr. Genereux, thanks so much for being with us. Tell us a little bit more.
First of all, thank you for the interview. It's a real pleasure. We just hot off the presentation. So we all know that the EARLY-TAVR trial was presented at TCT this year and published in New England. It was about patients with severe aortic stenosis and no symptom, randomized to early TAVR versus clinical surveillance. It was 901 patient, and the primary endpoint was met, so early TAVR was superior to clinical surveillance in regard to the primary endpoint of death, stroke, and unplanned cardiovascular hospitalization, but also superior in terms of death, stroke, and hospitalization for heart failure. The goal of this current analysis that we did is the first sub-analysis of the EARLY-TAVR trial, and what we try to look is to see first if there's difference in outcome in patients that underwent AVR in both groups, so early TAVR in the early TAVR group, and delay AVR in patient that was in clinical surveillance and they need an AVR eventually. So this is what we call the valve implanted analysis, just looking at a patient that received a valve. And it was around 800 patients. We had 388 patients in a delay AVR and around 444 in the early TAVR. And the primary endpoint that we used for this study was death, stroke, and heart failure hospitalization. And we had a reduction of 35% at the death, stroke, heart failure hospitalization in favor of early TAVR compared to delay AVR up to 2 years after the procedure. Then we did another analysis where we look how the patient present before the delay AVR. So there's three group of patients that convert to symptom, would convert to AVR. The first one, you could receive a delay AVR where no symptoms, which was the minority, 2%. You can come to the hospital with progressive valve syndrome or class 2 heart failure, about 60% of the patient. Or you can, I would say, more crash and burn, what we call acute valve syndrome with severe symptoms such as syncope, pulmonary edema, cardiac arrest with reanimation, class 3 or 4 heart failure. So the real stuff, which was 40% of the patient. What we look is the impact on outcome based on how you show up. So compared to early TAVR, and no surprise, in terms of death, stroke, and heart failure hospitalization, acute valve syndrome was associated with twofold increase in all outcome actually, death, stroke, heart failure, death and stroke, and also threefold increase in stroke compared to early TAVR. So the conclusion of this study is really, first, early TAVR should be the preferred strategy based on the fact that early TAVR compared to delay AVR decreased the incidence of death, stroke, and heart failure hospitalization. And also, acute valve syndrome before AVR, if you wait, is frequent, 40%, associated with increased death and stroke, but also stroke after AVR, threefold, which is very important. And it's hard to predict. So in light of those findings, we believe that early TAVR should be the preferred option.
Mm-hmm. Thank you. Yeah, compelling and thought-provoking results. So thinking about that and other data you've published, how has this affected your personal practice, and what do you anticipate in the future? What do you hope that the treatment of aortic stenosis becomes moving forward?
Yeah, so I think the first lesson of early TAVR is we need to refer and see those patients early to get organized. So if a patient has severe no symptom, we should see them first very quickly. We should do a CT scan quickly to decide, is it a TAVR, is it a surgery? So we plan ahead, and that's what early TAVR was so good. We mitigate mortality in both arms because we were ready and we were planning ahead. So first, refer those patients early, plan ahead of time, okay, plan early, and then you do a timely AVR. So for me, I say to my patient, I like to see you early. We need to get our ducks in a row, get the CAT scan, decide if you need a surgery or a TAVR. And I would say if you have symptoms, is a mild symptom, you have 3 months to treat the patient. If you have a very severe symptom, you should do this quickly within a week or in the same hospitalization. If you have no symptom, I think there's not a lot of actually there's no advantage to wait. There's no harm to do early intervention, and there's benefit in terms of death and stroke, rehospitalization for heart failure, etc. So my practice changed in a way that I want to see this patient earlier, and I want to organize those patients earlier.
Mhm. All right. Yeah, great. This morning we're with the ACC's FITsOnTheGo program. Dr. Genereux, tell us just a little bit more about your own experience as a fellow. How did you first get involved in clinical trials research, and what advice do you have for fellows who are interested in doing the same thing?
Yeah, so first of all, I still feel I'm a fellow. Time flies, it's very unfortunate, but I'm 20 years after my fellowship, and but I still feel with the same curiosity. So first of all, be curious, pay attention. For me, I'm a clinician guy, so I see a lot of patients, I do a lot of procedure, but I pay attention to every case. There's a learning in every case, and sometimes you have idea when you do a case that we should do this thing better. You see a patient, this thing make no sense. You look at the echo, this thing make no sense. We should do things. So first, be curious. Challenge the guideline. The guideline meant to be recommendation that need to be that change through time. When you look at the first guideline to now, things change, and get involved with a mentor that did it successfully before. Sometimes people try to associate themselves with the mentor. A mentor cannot teach you what they don't know. I think it's important to go see people that publish, the people that are successful, and they can really take you under their wings, or at least you learn just by watching. So I think to surround yourself with great mentor. I've been fortunate to be involved in New York with the Columbia Cardiovascular Research Foundation that really jumpstart my career with mentor like Marty Leon, Greg Stone, etc. So, and Roxana Miran. So I think stick with the best, learn from the best, but stay curious and be creative. And just for me, try to create things and to improve the field and focus on the patient. The answer is with the patient.
All right. Well, Dr. Genereux, thank you so much for your time this morning. Thank you for your own curiosity and leadership. A lot to take away from this morning's discussion. So for more videos like these, check out our channel at youtube.com/FITsOnTheGo.